It's a fantastic CV, and I'm sure I won't do justice to it. But you have lived in two different continents, and you're managing a global work, and you are a genuine ambassador for turning the world upside down. So that is my real learning from what your work has been. I mean, there are obviously lots of positions you held. You are the chief executive officer of Pakistan Institute of Living and Learning, and a professor of psychiatry at DUHS. But you're a fellow of the Royal College of Psychiatrists, and so we are very proud to have you as a fellow and our colleague in the UK. And with your doctorate in medicine from the University of Manchester, you remain involved both in the NHS and in research across the world. And I think you've been chief investigator for a number of research projects with Medical Research Council, Wellcome Trust, NIHR, and Grant Challenges Canada, which I think just shows the breadth of your work. And your research interest being obviously women's mental health, intellectual disabilities, self-harm, and suicide prevention in low-income countries. So really looking forward to your talk. I won't take any more of your time. Welcome, and over to you.
Thank you so much. Thank you for your kind introduction. We've had some fascinating talks early on in our first session. And I'm going to talk about parental mental health. And we'll share with you the work that we've done in this area for over 20 years. And again, this is an area of major public health priority. So, Samin, I'll be requesting you to move the slides. So can we move on to the next slide, please? This is just my disclosure. So, Pakistan and the challenges that Pakistan proposes or puts forward. Imran has talked about it. Pakistan is the fifth most populous country in the world. A third of our people live below the poverty line. We have low literacy rates, but we are also the riskiest place in the world to be born in. Of every 1,000 babies that are delivered, 46 die before the end of their first month. We have high rates of depression, both in our men and women, and we have one of the highest rates of maternal depression in the world. Sadly, the babies who survive, 37% of them remain stunted, and this is a big issue. Our relatively newly elected Prime Minister, in his inaugural speech, made it a point to discuss stunting being a huge, major problem for Pakistan. Can we move on to the next slide, please? Maternal depression has huge implications on child outcomes. Depression starting in the perinatal period can stay up to 3 or 4 years after birth. And this is the critical period for child development in terms of their cognitions, emotional, and behavioral development. It can contribute to malnutrition, and I've just said about stunting. The work that we did in one of our studies, we did not find an association with low birth weight. But this is an area that needs more work. It can lead to childhood depression and subsequently depression in later life. An episode of maternal depression costs approximately £74,000. Of this, £25,000 are costs for the mum, and around £50,000 are child costs. So clearly there are huge implications of maternal depression, not just on mums, but on the child as well. Next slide. So our work started in the late 1990s. And for our first study, we looked at depression and social stress. This was in rural Pakistan, and we found high rates of depression in women, around 57%. And then we embarked on a journey of looking at prevalence and psychosocial correlates of perinatal, postnatal depression, because if we were to think about interventions, then we had to understand the social correlates. What we found was that low education, financial issues, stressful life events in the preceding year, and a previous difficult delivery were associated risk factors. We also did a study on validating questionnaires that detect maternal depression in Pakistan. And then we moved on to, next slide please, our first parent-based intervention study. This study was in rural Pakistan, and the intervention we used was learning through play. This was initially developed in Canada, and it was for lay health workers that were working with very high-risk ethnic minority groups. So the central feature of this intervention is a pictorial calendar, and it takes you through successive stages of child development from 0 to 3 years. It's based on Bowlby's theory of attachment and Piaget's theory of cognitive development. It uses little, but the language that's used is very simple, so parents with low literacy can understand. And it promotes parent-child attachment, learning and involvement, and it provides parents with about understanding healthy growth and child development. The other thing we did in this study was we used lady health workers to deliver. And you heard Nusrat speak earlier about task shifting, because this is a huge issue. We produce very few psychiatrists, although we do have a yearly output of a large number of community health workers and psychologists. So I'll tell you a little bit about these lady health workers. These are members of the local community. They have done their secondary education, and they're trained to provide preventive mother and child care. So each lady health worker is responsible for 1,000 moms. And because they are living in the same community, they are in a very good position to engage with these moms because they are respected by the families. And what happened with this study was they did a half-day workshop where they went with the moms through the calendar, and then they would spend weekly 20 minutes with individual moms going through the different stages. So we had 302 moms that were randomized into the intervention and the control group. We found that the moms in the intervention group, their knowledge and attitudes about infant development improved, but there was no difference in their level of mental distress. Next slide, please. So we then, in our intervention, integrated Professor Atif Rahman, who's a very dear colleague of ours, his Thinking Healthy program, which is here and now problem-solving approach, and it uses CBT techniques of active listening, challenging negative thoughts, working with families, homework of putting what they've learned into practice. And we also integrated and adapted Jeannie Miranda's group CBT manual to make this into a group intervention. We did this study in an urban, sort of two towns of Karachi, the two areas of Karachi. 247 moms were recruited and randomized. And in the intervention arm, there was an improvement in their depression, their parenting stress reduced, self-esteem improved, and interestingly, the height and weight of children was better in the LTP plus group, but it wasn't statistically significant. Next slide, please. We then tested this intervention in mums who had malnourished children. And these were mums that presented to two large public hospitals in Karachi. Malnutrition, again, because it leads to developmental delays. Again, a big issue for Pakistan. And our Prime Minister has only recently, he has started a huge funding relief program to address this issue. So 107 mums, randomized, significant reduction in depression scores, in their social support, quality of life, and child outcomes improved. Number of days with diarrhea and chest infection reduced significantly. Next slide, Samin, please. So with this group, we did a nested qualitative study as well, because we wanted to understand the experience of these women. It was a small study. We had 8 participants in the pre-intervention and 7 after post-intervention. The women reported that they felt listened to and empowered. Next slide. Some of the quotes from these women. This is before intervention. When I was angry, I often used to beat my children. Following intervention, quote, my mind has changed now. I try to solve my problems myself. I learned new ways of raising children. Now I better take care of their health. Next slide. This then led to our Grand Challenges Canada funded Roshni 1 study. Roshni in Urdu language means a ray of light. And this was to test the efficacy and acceptability in a larger sample size. So this was done in one of the towns. Karachi has 18 towns. One of these towns is Gadab town. It's rural, a poor town, has a population of around 450,000. It has 400 villages. A total of 120 villages were randomized, 16 to the intervention and 16 the treatment as usual. We randomized 774 depressed mums. Assessments were done at baseline, 3 and 6 months. The picture at the top is a picture of our group intervention that was held in Gadar. And the picture at the bottom is the Urdu version of the calendar. Next slide. Now, the findings from this study was that there was a significant improvement on all maternal, parenting, and child outcomes at 3 months, and this was sustained at 6-month follow-up. So their depression, anxiety, health-related quality of life, their perceived social support, and self-esteem improved. Parents' knowledge, attitude, practices of child development improved. They became more competent, their stress reduced, attachment improved. And child outcomes, by using ages and stages, looking at their communication, gross and fine motor, problem solving, and personal social improved. Next slide. You've heard Imran talk about how important it is for us regarding capacity and capability building. We have so far trained over 4,000 lady health workers and community health workers. A number of them are trained in the learning through play. So these were just some of the views from the community health workers who had this training on learning through play. It was more that it wasn't just that it was helpful for the people that they were looking after, but in their own lives as well. And I quote, in learning through play, we learned how to interact with our children as they will learn such behavior and will use the same behavior. A quote again, another quote, we discussed cognitive behavior therapy. We learned how women can change their thoughts. So they found it really useful. Next slide, please. The Roshni 1 results led to further GCC funding for implementing the LTP Plus across Gadab town. So in this, over 1,000 mums were randomized. 60 villages were randomized, but in this we had two groups. So one group was the LTP plus. This group received intervention by trained lady health workers of our implementation partners. Now, HANS is one of the biggest NGOs in Pakistan, Health and Nutrition Development Society. They are spread across Pakistan. They serve in local government health units, and they've been extremely supportive of us throughout our journey. So one group got the intervention from HANS LHWs. The other group was the LTP plus supported implementation. And the HANS were co-facilitated and supervised by our senior staff who were experts in delivery of intervention. We've only just got some preliminary results because the study has just completed. And what we found is that the supported group did significantly better than HANS-only group on maternal outcomes such as depression, anxiety, parenting stress, health-related quality of life. And the participants reported more satisfaction with the kind of services they received in the LTP plus supported group. So clearly this highlights the issue that it's not just about that we've trained somebody to then carry on and do the intervention without ongoing support, supervision in terms of the delivery of intervention. But we'll know more about it because, like I said, these are just preliminary findings. Next slide, please. Now, very interestingly, while we were doing with mums, these intervention groups, dads would look through the windows or they would approach our staff and say, all this work is happening with mums, why are we being excluded? So we've done work with dads, and we've got Dr. Ishrat Hussain later on in this session, who will be telling us about the work that we've done, LTP plus and dads. Next slide, please. So we consider this to be a cost-effective intervention. From the findings of our implementation Roshni 2 study, the cost from the trial was up to approximately $2,600 per quality adjusted life year. WHO recommends a cost of up to $80,000. So clearly, it's a worthwhile intervention, it's cost effective, and importantly, it not just addresses parental outcomes, but also child outcomes. Next slide. And this is my concluding slide. I want to share, and Dr. Ishrat will tell us a lot more about it because we are very, very excited. We were invited by GCC to apply for a grant, and we have been funded for a partner-inclusive LTP plus dads transition to scale across Karachi, population of over 23 million people. So again, an incredible journey for us. We started from generating local evidence. We developed, tested the intervention. We have implemented in one town, and then for dads, we did it in 2 towns. Now it's going to be across Karachi. We are very hopeful and very motivated that not that long, we won't have to wait that long, that we'll be implementing it across Pakistan. Next slide. So I just want to end by thanking all our funders, our collaborators, all the community health workers, community workers who've been relentlessly supporting us, and the participants without whom this work would not have been possible. So thank you very much. Back to you, Dave.
Thanks. Sorry, I was muted there.
No.
Nasim, fascinating presentation. And